When I talk about respiratory anatomy, I think of upper airway. In this context, I'm going to be talking about um, basically from the nasal cavity and the throat. The pharynx is the back of the throat, the mouth down to the voice box, and then lower airway. In this context, I'm going to mean the trachea, the airways, the bronchi that go to both lungs and down into the smaller structures of the lung. Respiratory complications in mucopolysaccharidosis can occur from the GAG deposits that cause or contribute to upper airway obstruction, which is kind of ear, nose, and throat issues, lower airway issues of the trachea, the large bronchi, or the smaller airways, a restrictive lung disease, which is like the stiff chest affecting breathing, impaired mucus clearance or poor cough clearance, having a weak cough sometimes, swallowing dysfunction, we call that dysphagia, or an obstructive sleep apnea can result in hypoventilation, not breathing enough, hypoxemia, lower oxygen levels, and of course, we see more pronounced hypoxemia here at a mile high, but this affects children with MPS even at sea level. So the complications vary by not only by which type of MPS, but also by the degree of severity or attenuation. So this is true within each of the conditions. And yet upper and lower airway obstruction, restrictive lung disease, sometimes these are more mild than some of the conditions that affect more neurologic and less muscular skeletal degrees like Sanfilippo, but still in all of them we see degrees of respiratory severity. And so we'll talk about these kind of by type as we go through. So upper airway obstruction, often the presenting symptoms of little children can be ear, nose, and throat concerns. So rhinorrhea or having a chronic runny nose, chronic ear infections with effusion, even affecting hearing, enlarged tonsils and adenoids. Macroglossia is the medical term for a big tongue. Pharyngeal narrowing or having a small throat, and then poor TMJ or temporomandibular joint mobility leading to inability to fully open the mouth. Laryngomalacia or stridor. Stridor's that noisy sound when you inhale, but from narrowing of the upper airway and throat. So this is a picture of a enlarged tongue. This picture in B is what I would call a normal larynx or voice box, and these are the vocal cords here. These tissues here are the arytenoids. That's the cartilage that enables the vocal cords to move. And then in MPS, we can often see these structures collapse. So these are the arytenoids here hiding the vocal cords. Similarly here, leading to that difficulty or noisy breathing. Lower airway obstruction can include subglottic stenosis, so just below the vocal cords where the airway starts to get narrow at the very top of the trachea. So just below this point can be narrow. Tracheomalacia or bronchomalacia. This is a floppy airway. And we see this in all sorts of conditions, but it can occur in MPS as well. This means that during regular breathing in and out or during coughing, if the trachea or the bronchi, the airway branches collapse, then it's more difficult to get mucus out. So the whole time when you really are trying to bear down and cough to release mucus, it gets stuck there because that same effort to push stuff out causes collapse of the trachea. So this is an example of that. This is a patient who's a baby who's laying on their back here. And you see, this looks kind of nice and open. The branches here, these holes are the openings, but in smaller airways up here, they're squishing shut. And so that's bronchomalacia that we're seeing here. And then this is a patient, I don't know if I can play this video, I'm gonna try. Yeah, so I thought this was a granuloma at first blocking, but you can see the back of the tracheal wall is coming up and almost completely collapsing, covering the breathing tube here. And so this can be very severe. In other children that have just this posterior tracheomalacia, there's a procedure called a tracheopexy where you can move the esophagus to the side and suture that tracheal wall to the spine. And it can be helpful in some conditions. These are some babies that had the procedure that we published this little case series, and you can still see, you see this kind of squishing here but even after the surgery, in some cases, it still stays squishy. So that floppiness or malacia isn't always fixed by the surgery. I would say in MPS, in addition to the malacia, the floppy airways, we see stenosis. And so this is from gag deposits or narrowing. It can also be from external compression. Severe scoliosis can lead to this, but where the trachea is both narrow and convoluted. And so this is from a textbook, a normal, let me back up if I can, a trachea that's wide open with the anterior, the horseshoe-like rings of cartilage in the posterior wall, the wall in the back being normal. And then over here, this is what we could see in a child with MPS, where it's just very convoluted. And this is an MRI scan reconstruction. So you can see here this how curvy it is from gag deposits really leading to this stenosis. So this can really be severe. And that, like we just in some of the question and answering earlier this morning, we're talking about tracheal reconstruction. These are the patients where it's so narrow where this becomes considered. Of course, tracheal reconstruction is a big surgery. That's having the chest opened and doing things to try to slide and adjust the trachea to make it be broader and more open. And we wouldn't put somebody through that unless their symptoms were quite severe. Small airway inflammation is something that can, if I think of as a pulmonologist, we have to breathe through all these airways that get progressively smaller as we get down to the small air sacs in the lung tissue. If those airways get swollen, it's much harder to move air through. And so whether it's from aspirating and swallowing dysfunction that leads to swelling in the airways or recurrent infections, bronchitis and pneumonia, any sort of thing that causes inflammation, if you think of like when you get swelling in your finger because it's jammed or something swells up, it gets bigger. But if we're talking about an airway, swelling on the inside of that tube shrinks it down and really makes it harder to breathe through or to get secretions out of because of the swelling. And then asthma. Asthma is no more common in MPS than in everyone else, but asthma is common. Like as many as 1 in 8 children have asthma. And so that can happen too. And that means the really small airways will tighten up and that causes wheezing. And then we think of medications that can dilate. So bronchoconstriction is the tightening, bronchodilation is the relaxing that medications can do to treat asthma. And so I often have to think about, does my patient who has MPS also have asthma-like symptoms? So when I think of restrictive lung disease, I'm talking about that I mentioned earlier, the stiff chest. So this can be from kyphosis, like Dr. White talked about, that back bending forward, often in the kind of lower chest, high lumbar part of the spine, and from flattening of the vertebrae, scoliosis, where that same spinal column is either rotated to the side or twisted, can really make breathing be more difficult. The ribs in MPS can be abnormal, kind of more oar-shaped and often kind of more horizontal. Our ribs, when we're relaxed, are kind of downward. And then when we take a deep breath and our diaphragm drops, other muscles cause the ribs to kind of, I think of it like a bucket handle. The bucket handle comes up and that makes the chest bigger and able for us to breathe in. But if those ribs are already out sideways, then it's harder to take a breath. So all of this can lead to more difficulty breathing. Unrelated to me, I'm a lung doctor, so we get below the diaphragm and I start to think that's out of my expertise, but having a large liver and spleen called hepatosplenomegaly, that in the belly can push the diaphragm up and also make it hard to breathe. And then chronic lung disease, like I mentioned, recurrent infections, often children with medical complexity suffer from kind of getting one bad pneumonia, getting almost back to baseline, and they might even seem 100% back to baseline, but there's still some sort of injury that's chronic that's left behind. The next illness pushes a little bit. So even if step by step, it seems like we got back to where we were before we got sick, over time, there's this kind of buildup of serial infections that can lead to progressive decline of the respiratory system. Aspirating, like I mentioned, I'll talk a bit more about in a second, and having trouble getting the mucus out are issues we see. So impaired mucus clearance, the tortuous airways, like I mentioned, being physically obstructed by gag deposits, from the physiology, from having an ineffective cough or reduced lung function. And so what do? We think of treatments like albuterol. Before I mentioned albuterol is one of those bronchodilating medicines. It's an asthma medicine. But in addition to opening up the airways, it also increases what we call ciliary beat frequency, but cilia are the little microscopic hairs on the lining of the airway mucous membranes, and that cilia beats to help move mucus from the lower parts of the lung out up the trachea and then to be either coughed out or swallowed. And so that the frequency of those cilia goes faster with albuterol. So that's often why we recommend at the beginning of an airway clearance treatment taking albuterol. And then children with MPS can also benefit from chest physiotherapy. So I think of that as like breathing PT. You know, you're really trying to do what you can to help with breathing. And so CPT can be manual, where we kind of do, for little babies especially, kind of cupping and pounding on the chest gently. Or a vest is, the medical term for vest is high frequency chest wall oscillation, but we're shaking the outside with like an inflated vest that vibrates, that can help loosen up mucus so it can be moved out more easily. And for some patients that have a weak cough, there are devices called cough assist. It's insufflation, exsufflation, which means air gets pushed in and then sucked out. And that can trigger a cough and really help. You put a mask over the face and these cough assist device can really help, especially in cases of muscle weakness. Swallowing dysfunction is a huge issue. Of course, we want children who can eat to be able to eat. If you have trouble swallowing, that's a risk factor for aspiration, meaning saliva secretions or actual food is getting down into the trachea, into the lungs. And so swallow studies, we used to call these barium swallow studies. Now we call them VFSS, which is video fluoroscopic swallow study. Basically, you're using fluoroscopy to light up and whatever you're drinking or eating, and then swallowing to look and see where things are going. So these studies are often done with the help not just of a radiologist, but an occupational and speech therapist, child life specialists in our hospital that really help to make sure that children can do the study and we can get useful information from it. But we have to have a high index of suspicion, because we call it silent aspiration when you don't just choke from drinking regularly, but you not choking is the kind of the problem. It's going down the wrong pipe and you're not noticing it. So if there's chronic cough or recurrent respiratory infections, often swallow studies can be helpful. And then one benefit of doing the study is they can look at different types of consistencies of liquid. So sometimes thickening liquids can be helpful and can be a game changer to where kids quit getting recurrent pneumonia because they've stopped aspirating, because now they're drinking a slightly thicker liquid. And then some will benefit from a gastrostomy tube for feedings. And of course, that doesn't mean you can't eat by mouth, just you're no longer 100% dependent on what you take in by mouth to eat. You get calories this way and can enjoy food by mouth. And kind of brings up an issue I even have here, quality of life. Like, to me, that is so important for my patients, for my conversation with families, is what are your goals? What matters? And all the medical stuff in the world, like I can say from a textbook that, aspirating is bad and we don't want to have infections. And to some families, like doing everything possible to minimize that infection risk is huge for quality of life, because getting pneumonia means being in the hospital, and that's so disruptive to everything. But other families might say, I don't like that for sure, but eating is such a joy that I don't want to take that away. And so to me, my recommendations, I try to make sure aren't the most conservative possible thing that just minimizes medical risk at all costs, but that the medical risks are taken into account along with quality and along with goals, and that we get one life. And if your life involves eating and that matters to you, then like, geez, eat then. um, yeah, but still having the gastrostomy can be helpful for many kids. Obstructive sleep apnea. So I think of all the things I've already talked about. You have MPS, you have here airway obstruction, the different things we talked about, restrictive disease, other things like the spinal cord compressions, heart disease, neurologic impairments. All these can lead to sleep disorder breathing or sleep apnea, which can lead to hypoventilation at night and then daytime hypoventilation. And over time, that can lead to strain on the heart, progressive heart failure, and can be a big deal. So we take sleep apnea very seriously. Um, and yeah, it really is something that over time can become worse. So when I think about treating complications, there's a lot of things to take into account. But briefly, things like enzyme replacement therapy, stem cell transplants, gene therapy. You're hearing lectures on a lot of these this weekend, and I think these are exciting, novel treatment modalities that get at the underlying condition itself. And of course, that's really important. The things I'm going to talk about right now, I would say none of these are universally indicated for all kids with MPS. We have to think about what underlying condition they have, what symptom we're trying to help, and maybe these things will be helpful. And if they are, great. If not, my goal is not to just put children on every medication I have, but to be thoughtful about, is this helping? And if so, then perhaps there's a rationale for it. So for upper and lower airway obstruction, steroids decrease inflammation. So nasal steroids in the nose can often help early on with that kind of chronic runny nose, with more comfortable breathing. And even if nasal swelling is part of the obstructive sleep apnea, then treating that's important. Obviously, medications that are sniffed through the nose can get into the bloodstream. That people abuse that fact. But the nasal steroid tends to have low absorption by the body, so that doesn't worry me too much that I'm going to have negative side effects from steroids in the nose. Inhaled steroids, similarly, although too high of doses can have some longer term effects, but we're trying to decrease chronic inflammation in lower airways. And I put an asterisk there because really there's no studies saying that inhaled steroids are indicated for MPS. I think we have to be thoughtful, like I said, about the conditions. And as a pulmonologist, humbly, I'll say I prescribe a whole lot of inhaled steroids, no brand loyalty, just across the board. Trying to reduce inflammation in my patients' airways. And yet it's one of the less evidence-based things we do for a lot of conditions, aside from asthma. With asthma, controlling asthma, they're standard of care. And then bronchodilators, I mentioned for opening up airways if they're tight, but also for helping with mucus clearance. And then we want to treat respiratory failure with mechanical ventilation. So that can be invasive by being intubated, hopefully temporarily. Some patients with a tracheostomy, I actually direct our hospital's program, like the introduction said, for children that have tracheostomies and home ventilators. And yet sometimes with the narrow tracheas, this isn't really an option. Non-invasive, meaning with a mask. And again, the mask to get CPAP or those type of treatments, if you need it around the clock, that's not really great quality of life to have that on all the time, but many patients can sleep with it. So devices, these are invasive. So ventilators, so designed to be used, can be used for non-invasive, but also for children with tracheostomies. And there's a lot of different ones. And they each have their kind of pros and cons. We use all of these. The bottom one here, though, the LTV, that's kind of what's becoming the dinosaur. So I think I have one patient left on that one, but it used to be one that we used all the time. And then non-invasive devices, my credit here is Google Imaging, home CPAP, and home NIV machines. And I just put a bunch of them, but there are a lot. So like I said, they're able to support like CPAP or BiPAP at night. We've become more savvy with home non-invasive ventilation. So this is a little boy that maybe back in the past we might have recommended a tracheostomy for, but who is now on the cover of our manual at the hospital um, with this flexi trunk mask to be able to get support ventilation without having a tracheostomy or without being intubated. So our vent care program, we really take care of children with all sorts of conditions, including babies, a lot of that are premature, and we've standardized our process. We made this roadmap with kind of trying to help it be family friendly, but really trying to make sure that as we send children with technology dependence home, that it's safe. And there's just so many things that go into that: educating families, getting all the right equipment, often having home nursing. And so we really want to make sure we're preparing families for success. We do a whole lot of education, and it really does take a team to do this. So we have respiratory therapy and nursing. We do multiple modalities to really help learn with videos, with handouts, practice. Uh, we have formal classes. We used to do everything at the bedside, and we realized we're more consistent in education if we do some formal classes, but still hands on at the bedside is huge. And then addressing specific learning needs. So I've had some families where not only do they not speak English or Spanish, they speak a very rare language or they don't read, and we have to do things like make timelines and diagrams and color-coded medications. And our team really is tireless in trying to make sure families can safely care for their children. And then simulation. So simulation, every hospital in the country has sim. It's kind of the way we teach students or we practice emergencies, and it's all for staff and trainees to do things. But we were one of the first in the country to use sim to train families. And so we go into our sim lab that normally looks like this kind of hospital room, and we developed like a big banner to hang up that looks like a window at home, furniture, and we really try to um, create a scenario that feels home-like. There's this FBI mirror, and so there's the guy behind it with the computer controlling the guy. The mannequin itself looks a little bit creepy, but then we really want families to be able to practice um, responding to emergencies without placing their child at risk, so that if something happens at home, they're trained to do it. And really, families said in our publication that the debriefing process after simulation, where they go over what happened with the video with the instructor, that was the single most beneficial thing of all their training. Um, so by standardizing the process and everything, we were really proud of reducing our length of stay. So this blue line was the overall length of stay on average for kids that were getting tracheostomies and going home with ventilators. It was around 250 days in the hospital, really long. And then by standardizing, we brought this down. And then this is post ICU. So, of course, a lot of it's due to being sick and being in the ICU. But even after that, just all the logistics to going home took a long time. So we were so proud of this, and we had our roadmap, and we said, Colorado, we've decreased length of stay. Everyone else should copy our stuff. And then over time, it crept back up. And I was saying this is a nursing shortage. Of course, it's worse in kids that have been home before and or not ever been home before. So little babies, I think families weren't prepared. Families that have medical complex children already at home kind of know what they're doing. So if they progress to the point of needing a tracheostomy and home ventilator, they're they're maybe going to be able to get out of the hospital a little quicker. But that's this group over here, and you still see the same trend. It's worse for those that have never been home. But we said, okay, we need to help with this. So there's still a lot to do. There is shortages in home nursing. We know there's a lot of disparities that lead to this, and so we're really still trying to get creative in how to help our families, regardless of their resources. Certainly, when I say disparity, I mean that, like, the family that's got a lot of money can hire staff and can, woo people into their nice home to be home nurses, and it goes a lot more smoothly than for, say, a single parent that lives downtown and maybe kind of not the safest home environment. Then that mom's going to need home nursing even more, but have a harder time getting it. So, we want to address these healthcare disparities and try to have our patients, all of them, be safe, regardless of financial means and those kinds of things. So I'm going to end by talking about Zach. Um, Zach was so awesome. Zach had Morchio 4A, This is him. Of course, Morchio means he has his kyphosis. He had surgeries. He had halo traction here. He had multiple lower extremity procedures like Dr. White described. And I swear we didn't plan this out. Although as he was speaking earlier, I thought, geez, this seems like we did this on purpose. But Zach had Morchio, but he lived his life. This is him as a baby. He did karate. He played hockey. I love that little picture of him there on the hockey rink. Played piano, rode horses. Did things. And then when he was 10 years old, he had a complication. So we went in for routine femoral osteotomy surgery, had an epidural. We had this conversation a few minutes ago. The epidural caused paralysis from kind of mid chest down. Um, it was bad. Then in evaluating it, he had a cardiac arrest while they were doing a CT to look at what's the problem that's happening. And he ended up recovering from the cardiac arrest pretty quickly, but being intubated in our PICU, his trachea was so narrow, and he'd had conversations with his parents for a long time. They, in thinking about what's best for him, they really didn't want tracheostomy. And even if they did, I wasn't sure we could get a trach in there because his narrow little trachea, like I didn't know what size tube we put in. We tried to do a bronchoscopy and there's no leak around the tube, breathing tube. I could only just look through that tube and I tried to pull it back some and I'd chicken out and push the tube back down. So we talked to his family. They really felt like it's time to be done. He did make a wish a couple days before we were, near what we thought was the end. His Make-A-Wish was to see the Monsters Inc. 2 movie, which wasn't out yet. So that Make-A-Wish Foundation helped to get a pre-release. Then he had some of his buddies come over, and the ICU had to take him to the teen center while intubated in his bed with his buddies to go watch on this screen this secret movie copy of the movie that wasn't out yet. And then we all felt like, okay, he's made his peace. His family feels like we're in the right spot. And we withdrew support. And to me, withdrawing support, I've been there for the end of life for a lot of patients, and it's not my favorite part of my job by any stretch. I also feel like it's super important and meaningful. And to be there at the end, all of us have a beginning and end to our lives. I hope mine's a long time from now when it ends, but there's none of us that don't have an end to our lives, and to be there for the whole story and to be there for the end, to me, it's so meaningful. And I was there for Zach's. So we took the breathing tube out. We still, put a mask on, and I said bye. And the next day he was still on BiPAP. And he actually lived. So we withdrew support and he lived another 10 years. So this is Zach after. So he's paralyzed. He didn't get a trach. He had his non-invasive support, but he graduated. He went to prom. He went swimming. He did a cruise. So many cool things. So anyways, I was so inspired by Zach. So in summary, children with all types of MPS are at risk for respiratory problems. Much can be done to support their breathing in MPS, and our goal is to breathe as comfortably as possible for as long as possible. And I mentioned our home vent program. It's large. I talked about that because that's what I do. But honestly, I just went through our database of the 108 patients with MPS that I could easily pull up through our hospital record. Only 2 had tracheostomies. So it's not common. But non-invasive is very common. And children with MPS can and do live amazing lives. Some of you are adults with MPS, so you keep doing that, even beyond being children. So I told you about all our team. It takes a village. I'm not going to list everyone off. I will point out Zach's parents, Noreen and Craig, who shared those pictures with me. And really, it's an honor to be able to be the speaking, but I couldn't do what I do without this huge team of therapists, of RTs, nurses, other colleagues, and really it does take a village. So thank you.
Financial related for all of the perspectives that you brought to us. Are there any questions?
I remember, well, 1998 is the Elm Key, 19 now, these guys said. The one thing I hadn't heard before was the cough assist device. Can you tell us a little bit more about that? I've heard the chest vest, and a lot of people used to push to that camping on that kind of, as he's needing that, I'm getting managing
Yeah.
chest for muscle therapies. He's lost it after the two year part. I think that was very so yeah, I think the office.
Sure. And so the vest systems, I think for a baby, you can easily do, it's a real estate question. You can cover the front and back of a baby pretty quickly but when you get bigger, there's just more to pound on. And so having the shaking is super helpful. And I've had some families call it a game changer to get a vest. Having MPS is not one of the immediate criteria to qualify for it. So often if a doctor prescribes it, it's going to be denied, but they can petition. So just get your doctors to fight back and write a letter of medical necessity. Sometimes it's a peer-to-peer conversation. That's where the prescribing doctor has to talk to the doctor that sits at a desk at the insurance company and says, that argument is basically like, hey, I know this is an expensive device, but one day in the hospital will pay for it. So do yourself a favor, do your insurance company a favor to save some money by spending some money right now. So then Cough Assist, same thing. And Cough Assist is a brand, but I tell you it because you can remember Cough Assist. If I say, go ask for mechanical insufflation, exsufflation, like I don't expect you to do that and be able to spit that out. But it basically, when I was a med student, learned about ventilation, and we learned about when you're on a ventilator, when you want to get a breath, you increase the pressure you're pushing in. And when you in between breaths, you lower that pressure so you can exhale. But a patient who's got a breathing machine, it never stops pushing air in. Like in between each breath, it pushes less so you can exhale. But you need to push some in to keep things open. And I thought, well, that's kind of, my intuition would say to help someone breathe, you push air in, you suck air out. Why don't ventilators do that? And the reason is because as soon as you suck air out, that makes you cough. So then that's where this machine does is pushes air in, pulls it out, and so for somebody that has a weak cough, it really can help. And so again, I present this as a broad thing, like not being the one to decide who specifically needs it of any of you in the audience or your family members, but it can be helpful. There are a number of brands that do it. Some kind of push air in and oscillate a little and then suck out. Others just go between two pressures. And it's not something you have on all the time. It's something you incorporate into your treatments. So often a patient will do albuterol, then do their shaker vest, then cough assist, and then end with any medicines they want to inhale that, like a steroid or something that you want to leave in there. You do those at the very end.
Really nice talk, and we knew Zach well also, and his family was tremendous. But two areas to comment on. One, our older patients with Hunter, we have this unusual narrowing of the airway in even attenuated patients, and whenever they get a respiratory infection, they become severely ill and could be in an ICU. We comment on use of enzymes versus we've gone over more to hypertonic saline and trying to mobilize mucus that's not coming out. The other comment you mentioned with Zach with an epidural being in place, and I don't think we brought that up, Clayne, in your talk on anesthesia. Bill McKinsey has put out a series and has cases as well where epidural has led to infarction as well, and try to avoid that in your anesthesia procedures with these
Yeah.
kids or adults. Comment on the severe sort of acute illness and recovery of treatment of patients there. That would be great.
Yeah. Thank you. Yeah, I agree with your comments, and I feel like as a physician, it's very easy to play Monday morning quarterback and criticize others. I think in the context, people are trying to do what's right, and complications happen. So even with neuromonitoring, even with, the best approach, sometimes there are negative outcomes. And yet I think that caution about epidurals, that really thinking through what's the best approach, you do want to be in a center that not only has expertise to prevent, but that in those unfortunate situations where complications do happen, there's a pediatric ICU or an age appropriate ICU that can help moving forward. And yeah, thank you.
My son has years after strength and eventually he tried to fix them to help him skin ADHD. At the time he started it, he was on oxygen at night and pulmonary issues and stuff. After being on Dupixent for a year, all his pulmonary stuff disappeared. So we're on oxygen at night, he no longer had sleep apnea, and we had to the kinds that off Dupixent to get him vaccinated and stuff. And I've seen a little bit of a creep with his pulmonary stuff come back. But I was wondering if that is possibly now a future treatment for some of our kids' pulmonary issues. Because I strongly believe, even though we gave him the shot for one reason, it made it now.
Sure. Yeah, it's an encouraging anecdote, your story of telling that, and certainly I can't comment specifically for my knowledge on the impact of Dupixent specifically on MPS respiratory conditions. I don't think it's been studied, but I will say that in this day and age, it's very exciting how monoclonal antibodies are being developed to effectively treat all sorts of conditions. And whether it's enzyme replacement, gene therapy, antibody therapy, stem cell therapy, there's so many ways that the game is being changed, and for good, for helping our patients. So thanks for sharing that awesome story.